Good morning, everybody. Welcome to PCH Grand Rounds. It's new intern day. Welcome to all the new interns. We're very excited to have you here and excited to get to know you and to work with you. I think PCH benefits greatly that the interview season is in the winter and that the first week is in June. I'm not sure how many of you, if it was 120 degrees when you came in your interview day, would have actually chosen Phoenix Children's, but welcome. It does get a little bit cooler than this in the summer, and the storms come in July, so that's always nice. We have two speakers this morning, Dr. Michael Henry and Dr. Kristian Schafernak. Dr. Henry is a member of our Hematology Oncology Division, and he is the director of the Histiocytosis program. Dr. Schafernak is a staff pathologist, and he is the section chief of the molecular pathology and the microbiology sections. They will be using a audience response system this morning. We're used to this in Grand Rounds, but for the new interns, they're going to have a few slides that they're going to have a question, multiple choice question that you're actually going to text the answer to, and we're going to see the responses from you live on the screen. So as they get to those slides, they'll kind of give you a brief introduction, but it's very easy. You just text a number, and then you're off and running. So without further ado, we will welcome Dr. Schafernak.
Thank you. Who feels like they have a really good grasp on what HLH is? Raise your hand, please, if you feel confident. Okay. So if everyone raised their hands, we were going to just dismiss you early. But instead, since there are two of us, we have a special 2-hour Grand Rounds today. Just kidding. But we have a lot of material we're going to go over, and we're going to talk about this from both a diagnostic and a therapeutic standpoint. So why should you care what HLH is? Well, first of all, many of these patients are critically ill. The criteria are nonspecific if you take them individually. As a whole, they constitute a constellation of findings, which is very characteristic of this HLH pattern. Some of the tests, though, need to be sent out to a reference lab. That takes extra time, so you need to recognize potential kids with HLH promptly so you can do the right testing and institute life-saving therapy, potentially if that's what's needed. So we're going to talk about this from a hematopathology perspective and from a hem-onc perspective, and we hope that you learn something, and we have a lot of material to go over. So first, we have no relevant financial interests or relationships to disclose. We do want you to understand by the end of this hour the overlapping functions of macrophages and dendritic cells. They actually have a lot of things in common. We want you to be able to rattle off the diagnostic criteria for HLH, and more than that, understand the pathophysiology that they represent and recognize that HLH is a disease spectrum which can present in a lot of different ways, and there are also a lot of lookalikes. So this is how it's going to go this morning. We'll start off with a definition of HLH, which is hemophagocytic lymphohistiocytosis. I'm going to talk about a very sad, kind of heartbreaking patient from my last job, and hopefully that will set the stage for understanding this disease, knowing what normal macrophages and dendritic cells do, and how they can go bad. We'll talk about the individual diagnostic criteria. We'll talk about triggers. So there are infectious triggers or malignancies or rheumatologic or immune conditions which can be associated with HLH. We'll go over a really nice mouse model. I promise it's like 2 slides, so you're not going to fall asleep and get lost and stuff like that. Then comes the fun part. So Dr. Henry will come up here and do the audience participation part, and he's going to ask you, is this HLH or not? And so I think he has some cases, and then he's going to talk about treatment, and hopefully you'll see how that treatment is rational given the pathophysiology, and then we'll kind of just bring it on home. So here's our definition. So HLH is a syndrome of extreme inflammation. I'm sorry I'm reading from the slide, but this is extreme inflammation occurring in association with genetic defects that involve CD8 positive T cells, which are called cytotoxic suppressor T cells, or NK cells, and or a wide variety of triggers. And like I mentioned, there are a lot of infections, there are certain cancers, and rheumatologic disorders that are associated with HLH. And by having this prolonged, excessive inflammatory immune response, it leads to a lot of cytokines, or toxic hypercytokinemia, or cytokine storm. And so this is, I think this is Arizona. I don't know if this is Phoenix. Hope it's not today, right? That's Phoenix. So, one? Oh gosh, okay. So, and what happens is you end up getting end organ damage from this cytokine storm. So we're going to talk about a case from my last job. I had worked in private practice before, starting in 2012 at Children's Memorial Hospital in Chicago. And this was rather early on at Children's Memorial. And so we had a 9-year-old boy who had a history of recurrent ileocecal Burkitt lymphoma. He had had a an auto stem cell transplant after his second, or his recurrent Burkitt's. And he presented with a rash, intermittent fevers, myalgias, arthralgias, and lymphadenopathy to the hemonc clinic. And the very senior oncologist said, oh, given his atypical lymphocytes on the peripheral blood smear, which I'll show you in just a second, given his pretty high EBV viral load of over 1 million copies per ml with a positive EBV IgM and a negative IgG, that this was all consistent with mono. But given his history of Burkitt's and a stem cell transplant, she was worried maybe about an EBV-related lymphoma or lymphoproliferative disease. And he was admitted directly to the PICU because of some respiratory issues. So this is the peripheral blood smear, and it shows 2 lymphocytes. Both of these we would recognize just as reactive lymphocytes. Very soon thereafter, we got a pleural fluid, which didn't show any Burkitt cells in it. We also got a bone marrow, and this is the bone marrow aspirate that we can read right away. And as you can see, I'm going to see if this laser works. So right here is a hemophagocytic histiocyte. This is a macrophage histiocyte which has ingested and is degrading a couple of blood cells. So, this is hemophagocytosis. This is what we're going to look for in the bone marrow. And there were some other findings in the bone marrow. This is a core biopsy section, though, and you have to use your imagination a little bit, but can you see these little blobs in here? So this is hemophagocytosis in a tissue section from the bone marrow. In addition, we did some flow cytometry studies. We did immunohistochemical stains, and just for your point of reference, when we have this brown staining, that's positive, okay? So all of these brown cells up in the corner, which stain for CD3, are T cells. And Burkitt's is a B-cell lymphoma, mature B-cell lymphoma, which expresses CD20. And we just have this sprinkling of B cells. And so this doesn't look like there's any Burkitt's in the bone marrow. If we look at the CD3 positive cells, we want to know what percent are helper T cells, CD4 positive, and what percent are cytotoxic suppressor, CD8 positive T cells. And as you can see, the vast majority of these are CD8 positive cytotoxic T cells. This staining is kind of this weak blush, and this is actually probably from the macrophages in the bone marrow because they also stain but weakly for CD4. We did a CD68 immunostain, which stains macrophages, and there are a lot. And this is an EBER in situ hybridization. So instead of brown being positive, blue is positive here. All these nuclei are positive for EBV. So this is a lot, actually. So I was happy, we made this diagnosis of EBV infectious mononucleosis, and with the other criteria, it looked like he had HLH, and this is, I don't know, maybe the first case of HLH I had diagnosed on a bone marrow. So I was happy about that, but the story gets a little bit convoluted. So he had his first Burkitt lymphoma when he was 3 years old, and this is the karyogram from that. And you all remember the, what's the translocation that you see? I forgot, because I'm so nervous. What's the Burkitt translocation? 814, yeah, I saw someone mouthing 814. So 814, so the MYC gene is on chromosome 8, and it gets juxtaposed to the immunoglobulin heavy chain gene on chromosome 14. And here we don't have an 814 translocation. We actually have a variant translocation, which is an 8-9 translocation. But that's something that is described in Burkitt's. And then when he had his, quote, recurrence 3 years later, he actually had an 814 translocation. So here's the 8, and here's the 14 right here. And we did FISH to metaphase to prove that there's juxtaposition of the MYC and the IGH genes. Unfortunately, there were only 2 metaphase cells which grew. One was normal, and then the other one had this 814. So although it was a non-clonal abnormality, this is the very classic finding that we would see in Burkitt's. And so to me, this looked like a weird case. I didn't have the slides. I wasn't involved in the diagnosis of those cases, but they looked like they were genetically distinct. I thought they were probably 2 different lymphomas rather than a recurrence. So what else did he have? He had neutropenia and thrombocytopenia. He had high triglycerides. He had low fibrinogen. He had a pretty high ferritin. So these are all features which come together to form this HLH pattern, and these are these diagnostic criteria. So we ticked off, 5 boxes of the 8 criteria, and we needed 5, and so it's HLH. But 2 days later, he took a turn for the worse and actually died that morning, and I got a phone call from that very senior oncologist about XLP testing. So I will admit to you, I didn't know what XLP was. I'm not going to come up with some funny thing that it stands for. I bought myself some time. I said, oh, let me see where we send that testing. And then I got onto, Dr. Google, right? And so actually, I read about it too. So in this book called Diagnostic Pediatric Hematopathology, this is what it says about X-linked lymphoproliferative disorder, XLP. Fatal infectious mononucleosis is relatively common. It's the presenting feature in about 2/3 of cases. So that kind of makes sense. He had a fulminant EBV infection, right? And less common but important is EBV-induced HLH, and that's exactly what he had, right? And then this was the kicker. So about 1/3 of kids with XLP develop a lymphoproliferation. About half of those have Burkitt lymphoma, that usually extranodal, mostly in the ileocecal region, and a characteristic feature is the tendency to develop second lymphomas. So these look like they were 2 separate lymphomas. History of Burkitt lymphoma in a male child that appears to recur after a long period of remission should prompt the evaluation of that patient for XLP. So this sounded like really plausible. So we did the gene testing on some premortem blood, and he in fact was hemizygous mutant for the gene SH2D1A, which is responsible for X-linked lymphoproliferative disorder 1. And what does that mean? He should have gotten an allo transplant. Maybe he would still be alive and not have died from mono. He has 3 brothers. He has sisters who could be carriers. And it would have been important to identify this and then to make sure he gets the right sibling donor if he were going to get a transplant. So this is a really, really hard case and really tragic too. So I won't ever forget this, but I want to use this kind of as a springboard for discussion. So what can we learn from this? We can learn that there are triggers. EBV is the most common viral trigger for HLH. Some people, even if it looks like they have a very clear trigger for their HLH, might have an underlying genetic immune deficiency like he did. And there's different ways of testing for that. So you could look by flow cytometry, or you could do gene sequencing. And it's not only important to test the patient for familial HLH, but if they in fact do have that, to test family members too. So we're going to switch gears a little bit. Here's a macrophage mugshot. And so, there really was a father, someone credited as the father of the macrophage, who was Metchnikoff, and in the late 1800s, he pricked larval starfish with splinters, and weird, I know, and also put some dye on them and stuff. And so he found that there were cells that were unrelated to digestion that would surround and engulf these splinters or dye particles. And so that was, I guess, the kind of the beginning of macrophages, right? And, that's really not all they do, though. They don't just eat stuff up and, process it, but they can also present antigen to T cells. So in my, earlier simplistic view of macrophages and dendritic cells, I thought of macrophages as these kind of ovoid cells. You see up in the left corner, here's a macrophage. And, it's kind of implied by the name, right? Big eater, that they're going around eating stuff. But they actually do a lot of the same stuff as dendritic cells. Dendritic cells have kind of more this starry appearance with these dendritic processes, right? And so on the photo that we have, again, we have a brown stain, and this brown stain is CD1A. And so this is staining Langerhans cells in the lung. This is bronchial mucosa. And normally, Langerhans cells, which are very involved in antigen presentation to T cells, they hang out beneath the epithelium of, almost exclusively, beneath the epithelium of the airways in the lung. And what they do is they extend their processes out over a large surface area, and then when the epithelium is compromised, then they get exposed to antigens. And so if these are harmful ones, there will be an immune reaction. If they are harmless ones, then we'll develop a tolerance for that. So what they do is they end up secreting some cytokines and chemokines after acquiring a mature phenotype, which is after they've been exposed to the antigen. And then they upregulate some co-stimulatory molecules and cytokine receptors, and then they go to lymph nodes, and in the lymph nodes they present the antigen to the T cells. So there's this immunologic crosstalk with these cells, right? But the reality is macrophages and dendritic cells really do a lot of the same things. And if we take a look at their family tree, most of the dendritic cells, which are down here, are derived from a common bone marrow progenitor, myeloid progenitor, as macrophages are. The notable exception is follicular dendritic cells, which are in the germinal centers of lymph nodes. Those are derived from a different stem cell. So we talked briefly about what normal macrophages and dendritic cells will do, but what happens when they go rogue. So here's a slide from a 37-year-old man with thrombocytopenia. This is Gaucher disease. And so if you look at all of these large cells, this is a higher power inset, but you can see they're really, occupying a good amount of real estate in the bone marrow. These guys, this result because there's a deficiency in the enzyme glucocerebrosidase, so there's accumulation of that substrate in the bone marrow and in different organs. Tumors of macrophage histiocytes are pretty exceedingly rare. And this is a case from an autopsy I did on a 61-year-old man who had shortness of breath. And you can see there's an enormous mass within the left ventricle, and this was an histiocytic sarcoma, really rare. So there was a recent revised classification of histiocytoses and neoplasms of macrophages and dendritic cells, and just very briefly, there's an L group. So this comprises Langerhans cell histiocytosis, indeterminate cell histiocytosis, Erdheim-Chester disease, and disseminated juvenile xanthogranuloma. There's a C group, which is for cutaneous or mucocutaneous histiocytoses. There's an R group for Rosai-Dorfman disease. I don't know how many people have heard of that, but we know about it in pathology. There's an M group for malignant. So this is going to be histiocytic sarcoma or the dendritic cell sarcomas. And then finally, there's an H group, which is for HLH and for macrophage activation syndrome. MAS, or macrophage activation syndrome, that's like the rheumatologic version of HLH. So here are the criteria. So you can either have a molecular diagnosis, so this is autosomal recessive inheritance, or for a couple of X-linked genes, you would have to be a hemizygous mutant, a boy, to have that. But that's not the typical way that the diagnosis is going to be reached. Normally, someone's going to say, we have this really sick kid, maybe he has HLH, and then you get out your list and you say, oh, okay, let's see how many criteria this guy has. And so, fever, note that this is like 18 degrees colder than the high today, which is gross, I'm sorry. Welcome to the new interns. Sorry. Splenomegaly, cytopenias involving at least 2 lineages, high triglycerides or low fibrinogen, hemophagocytosis in a few different organs, low to absent NK cell activity. That's not a test that we do here. So that needs to be sent like Monday through Thursday to Cincinnati Children's. Ferritin is elevated, and then here's another test, this soluble CD25 or the IL-2 receptor alpha chain. And so that's another test that goes out. And so it takes time to get those results back, but those are really important tests. And then there was a paper. So Mike Henry and I each have our favorite papers on HLH, and so they're both by Michael Jordan, not the basketball player, but he's a superstar to us, and yeah, pretty dorky, I know. So anyway, if you look at these different criteria, you can lump them into these 3 different categories, which reflect what's going on in HLH. So if you have low to absent NK cell function, or you have genetic defects in the granule-dependent cytotoxic pathway of those CD8 positive T cells or natural killer cells, you're not able to turn off the inflammatory response. Normally, when you no longer need the inflammation, you're going to be able to, cool it down, right? And in this case, you're not able to do the natural immune contraction. So there's this just crazy immune or inflammatory response, and you have prolonged activation of T cells and macrophages, and they're secreting a whole soup of cytokines, and then that ends up damaging organs. Significant immune activation is reflected by an elevated temperature, big spleen, elevated ferritin, which is from macrophages, elevated CD25, which is from T cells. And then what happens is you get this pathology, which is a drop in your cell counts in the blood, decreased fibrinogen, increased triglycerides, hemophagocytosis. And although this is not part of these criteria, we very frequently will see hepatitis or some type of liver failure, and CNS involvement is kind of more common than not in the pediatric population. So I'm not going to ask for a volunteer, but I normally would, and I would be the effector cell. I'd be the cytotoxic T lymphocyte or the NK cell, and whoever is the volunteer would be like the macrophage, which is the target cell. And so here you can see in this cartoon, there are a whole bunch of different proteins involved. And so these are those cytolytic or cytotoxic granules, and there's proteins packaged in there. And so if you have a problem anywhere along the pathway of the trafficking, docking, the priming for exocytosis or membrane fusion of these cytotoxic vesicles, then you can get HLH. And then there's this protein called perforin, which some have likened to a key. So this is the way that you gain access to the target cell. You punch holes in the target cell membrane, and then you shoot this granzyme B across the immunologic synapse, and then what happens is this activates a cascade of caspases which tell that cell, like, hey, why don't you kill yourself, or which is kind of a mean thing to say. But in this case, it would stop the immune, the crazy immune system from going on. And so people have likened that granzyme B to a gun. And so there are also some triggers. So we're kind of just, I don't know, we're using these words. So, so there are, again, 8 criteria that are used to establish the diagnosis. You have to have 5 or more of the 8. Fever is a very consistent finding. The notable exception is that in neonates, especially if they're born early, the HLH can be mistaken for sepsis because you don't always get fever. Splenomegaly is a pretty consistent finding. Actually, hepatomegaly is more consistent finding. I don't know why that's not one of the criteria, but whatevs. And then cytopenias, you very frequently will get anemia, thrombocytopenia. And this is not because there's tons of macrophages in the bone marrow just like eating like crazy the blood cells. It's probably more likely because of the cytokine production. So tumor necrosis factor alpha and interferon gamma will suppress and induce apoptosis of the blood elements. Less commonly, you see hypertriglyceridemia, hypofibrinogenemia. The hypertriglyceridemia is a result of decreased lipoprotein lipase activity because of those same 2 cytokines. And the hypofibrinogenemia is from high plasmin levels and hyperfibrinolysis caused by the macrophages, which are making a lot of plasminogen activator. Now, I hate the name HLH, or hemophagocytosis, right? Because you don't need that. You don't need to see that in the bone marrow. I've had real cases of HLH, like rip-roaring HLH, which don't have any hemophagocytosis. Like I look like crazy in the bone marrow, and then like I walk away mad, there is none. And furthermore, people haven't really clearly defined how much you need to see to check off this box. So normally we'll count 500 cells in the bone marrow. We'll put them into different categories. We'll say, oh, this is an eosinophil, this is a erythroid precursor, this is a lymphocyte, whatever. And so there was a study where Gupta took 21 pediatric patients with HLH, and they all met the criteria, irrespective of seeing hemophagocytosis. And if they saw one cell out of the 500 as a hemophagocytic histiocyte, which is 0.2%, then that was positive. Well, look, it's not too much better than a coin toss, right? 58% sensitivity. And then this other group, they took 3 HLH patients and 20 random controls, and they counted 9,000 cells, which is a ginormous waste of time, in my opinion. And that was their conclusion, that the overlap between normal and HLH patients, because these are just cells that are eating up dying dead cells. There's turnover, and the bone marrow is very green, and it wants to recycle iron and stuff like that. So that's not a really useful thing, and this is furthered by other studies. And people have talked about those different stains, like I showed you a CD68 stain on the bone marrow, but the reality is no one's ever looked at what is the normal quantity and distribution of macrophages using those 2 immunostains in the bone marrow. So what's normal and what's abnormal, like no one knows. And then finally, sometimes we get liver specimens, and we can see hemophagocytosis in there. And there's actually a few different histologic patterns that have been described. So lower absent NK cell activity, one of the problems with this, and so this is a cytotoxicity assay that goes to Cincinnati Children's, and they don't work on the weekends like in that lab. And one of the problems is sometimes HLH patients will have very few circulating natural killer cells. So this analysis doesn't always work. Furthermore, you can't use it to predict like which parents or siblings of people with familial HLH are going to go on to develop HLH despite having lower absent NK cell activity. And then ferritin has been a subject of contention, like where do you draw the cutoff? And if you look in adults, you can have just a crazy high ferritin of over 50,000, but there's a lot of other reasons that adults could get a marked hyperferritinemia: renal failure, hepatocellular injury, infection, hematologic malignancy, and inflammatory or rheumatic conditions are all more common than HLH is. And then this CD25 is actually a really sensitive marker. So I'm going to briefly kind of wrap things up. This is from Dr. Henry's favorite HLH paper, and so they had a mouse model. These are perforin deficient mice, and they infected them with this LCMV, which stands for lymphocytic choriomeningitis virus. This is a very common virus in mice, apparently. I mean, I'm an MD, but I'm not a mouse doctor, you know, so I don't know, like, what this stuff is. But I guess it's like kind of likened to EBV in humans. And because perforin is the most the earliest described gene mutation in familial HLH, they figured that, hey, let's infect these mice with this same virus, which causes a really brisk cytotoxic T cell response, and let's see if it will mimic the features of HLH in humans. And actually, like, it was all the same criteria and some of the same pattern. And so what did they have? So here's a few different things. This group right here is a wild-type mice, no virus. Wild-type mice got infected with virus, and the perforin-deficient mice got infected with virus. And if you look, the perforin-deficient mice that got virus, and this is all assayed like 8 to 12 days after they got infected, had a higher temperature, low fibrinogen, high triglycerides, cytopenias, big spleens, dramatically different cytokine profiles, a lot of CD8 positive histiocytes in the spleen, liver, and bone marrow, and really poor survival, right? So this really mimics, this is a great model for HLH in mice. There's some other markers like serum neopterin, which is something that we did a lot at my last job. There's some soft flow cytometry findings. Neurologic findings are really not good in kids, and they're present in 63%. So what we would advocate is do the full testing. If you are worried about HLH, don't just do a ferritin and be like, okay, I'm done. Recognize that, that this is a dynamic process, the clinical condition can evolve. And then even if it looks like there's an obvious trigger, please consider genetic testing. And we could do the gene sequencing, which is expensive and it takes weeks, or we can do some flow cytometry assays, which we also sent to Cincinnati Children's. Look for perforin, this LAMP1 or CD107A mobilization. This reflects exocytosis of those cytolytic granules. So, so if we have a really decreased resting natural killer cell CD107A expression can be seen in these genes, which encode these proteins which are involved in that whole trafficking and docking and priming and membrane fusion. And also, there's these X-linked things, so don't forget the X chromosome, right? There's some important genes which have recently been described on the X chromosome. I don't think you can see them here. There's the air guitar gene, which is called RIF. This is on the Y chromosome. There's the pre-adolescent fascination with arachnida and reptilia, which is called the MOM4U gene. And there's the Me2, that encodes the protein for inability to express affection over the phone. So, so just kidding, but this was like really in Science or Nature or something like decades ago. And so just remember there are these genes. Common to three of them, Griscelli, Chediak Higashi, and Hermansky-Pawlak, is albinism or pigmentary dilution. And then there's a whole bunch of bugs that are associated with HLH. Here's a ridiculous list, but it just shows the variety. And, you know, Mr. T, this is one of my childhood idols. And I had a parakeet that I named Mr. T, and he was kind of mean. But it like makes sense that if you have a T-cell lymphoma and these T-cells aren't functioning normally, that maybe you could get HLH, because there are a bunch of different T-cell lymphomas that have been associated with HLH. And in fact, I learned this recently from Dancing with the Stars, that he had a T-cell lymphoma, I think like on his ear. I think it was a cutaneous T-cell lymphoma. And then there's the rheumatologic conditions. So they did some surveys. identified criteria which overlap a lot with our HLH criteria. And so if you look at these criteria individually, they are really nonspecific, but together they form a pattern. And if you recognize this pattern, then we can work together and establish a diagnosis of HLH. So I'm done, but you're not. Dr. Henry's going to come up here and finish. So.
Okay, thank you, Kristian. That was great. And thanks all for being conscious with us so far, especially to the new interns. This is probably one of the only times that you're going to be conscious during grand rounds the entire year. So thank you for staying with us. Oh, I see you guys have already started this. Okay, so this is sort of like an intro slide to kind of introduce you to the concept for people who haven't done this before, and this is maybe review for people who have. So this is our poll everywhere. So what you want to do is you want to take out your cell phones if you want to participate, and you text PCH Med Ed, to the number 22333, and then it'll give you a confirmation, and then that you joined, and then you say A, B, C, D. So raise your hand if you get it. Any Holy Grail fans out there? Come on, you can admit it. All right, I don't believe you. So, all right, so I think you guys get the hang of this. Okay, for those of you who don't know what on earth I'm talking about, this is from Monty Python's Holy Grail. Okay, all right, I see a couple of nods. Thank you. Okay, so from the clinical sense, I want to take this opportunity to point out that if this is the normal immune response, to an infectious trigger, then this is the immune response in the presence of HLH. So just to give you some context, it's just completely overblown and inappropriate. So I know that Kristian already went over the diagnostic signs, but I am showing this slide to point out that most of the patients, if you look at the orange bar, is when they first present to medical care, and then the blue bars are when they're actually diagnosed with HLH, and there's most likely a lag of days there. Almost all the patients had fever, splenomegaly, cytopenias. You can see the rest. And you can see fewer patients had hemophagocytosis when they first presented, but when they're actually diagnosed, most of them do. However, there are a lot of patients that don't, as Kristian already suggested. Now, there are additional values that we look at, but are not actual absolute criteria, such as high LDH, transaminitis, increased bilirubin, and CNS findings, which we'll get to in more detail in a few minutes. So I'd like to now use your knowledge of using the Poll Everywhere system to play your favorite game show, HLH or not. So we get this question all the time as hematologists, especially from the ICU or from the general peds floor. Hey, I got this patient, blah, blah, blah. Is this HLH or not? So I'd like to kind of go over our thought process here. So let's imagine it's a Tuesday morning, and you have a 15-year-old girl who presents to your clinic. She's now well, but last month she had a fever and rash and splenomegaly. And her labs have now normalized, but last month she had pancytopenia, her ferritin was high, her fibrinogen was low, she had a transaminitis, but her monospot was positive. She actually had mono. So she didn't receive any therapy, and her symptoms resolved in 2 weeks. So how would you describe this case? So is it spontaneously remitting HLH? Is it so-called HLH spectrum disorder or near-miss HLH? Just mono, not enough info, or it can't be HLH because it's not Friday afternoon. So let's see what you guys think. Looks like the results are still coming in, but looks like just mono for the win. And I think, yes, that is what I'd say is correct. And actually, if I say correct or not correct, there, as we go over these cases, there really is no correct answer. There's a number of different ways to kind of, go about and think about this, but this is how I would approach it. As we'll see in the later cases, it gets a lot more muddy and a little bit more challenging to decide whether or not we have an HLH syndrome or not. Okay, so let's change this up a little bit. So same patient, okay, still pancytopenic, okay, and however, her fever persisted. She was then put in the hospital, and she got clinically worse until she received some IV methylprednisolone, and now it's tapering. So now how would you describe this case? Let's see what you guys think. Don't you wish you could say not enough info on the boards? So, okay, so we actually have a nice split here. So, I would say that for this case, let's go back and look at it. It is not spontaneously remitting because it's still happening, right? And she required treatment. And it's not just mono because, typically patients with just mono don't get hospitalized and require steroids to recover. I would probably classify this as an HLH spectrum disorder or a near-miss HLH, and we'll go more into the definition in a few minutes. But I think the important thing to remember is that a lot of these answers are just semantics. You really have to look at the clinical context to decide how to approach these patients. Okay, so now it's a Friday afternoon. You know what's coming, right? Okay, so a 2-week-old boy presents with fever, jaundice, and splenomegaly. Okay, and again, he has a familiar list of signs and symptoms. So he's got transaminitis, hyperbiliary, he's got pancytopenia, very high ferritin, low fibrinogen. However, his soluble IL-2 receptor is normal, and he's got he's got HSV by PCR in his blood. So what is this case now? Is it HLH? Is it disseminated HSV? Is it both, or not enough information? All right, so some of each. That's very interesting. So actually, this case would probably be, how I would approach it is disseminated HSV, okay? And the reason why I say that is because the soluble IL-2 receptor is normal, and we have a known cause. Now, there are hallmarks of HLH in this case, and it gets a lot more hard to kind of tease out the differences between actual clinical HLH and a mimic of HLH. So I'd like to refer to what I call, what actually Dr. Jordan calls the HLH ice cream cone. So down at the bottom in the cone, we have this HLH spectrum disorder, which the HSV child probably fits into. It nearly meets criteria. There's definitely an abnormal inflammatory response, but there's usually something else going on, for example, HSV or some other such infectious trigger. And then you have HLH disease, and these require immune suppression, like our second case, like the child with mono who ended up in the hospital requiring steroids. And then at the very tip of the cone, probably a vast minority of cases is the actual HLH syndrome. It meets classifying criteria. A number of these have genetic mutations, and these kids are the sick ones. So, so it's now a Saturday morning, and you're at home, and you realize that you have to explain what you really mean to colleagues when you say HLH. And so you think about these terms that we just kind of described, and all this talk of ice cream makes you want to go out for ice cream. So you do, and you think it over some more. So after you come back and you have sugar in your brain, you consider the 2-week-old baby again. Here we go. Well, I kind of already gave you the answer. So I think enough of you have answered to kind of go over this. So This again is probably going to be the HLH spectrum, which is, meets a lot of the hallmarks of HLH, but doesn't require treatment. It will go away on its own. At least, I'm sorry, I should clarify. The HLH part doesn't require treatment, but I would probably give this kid a cyclovir or something. I seem to have lost input. Any IT people out there? Escape's not working either.
Jumps up here, I think. Matt, if you're awake in the back there. Sorry. It's froze.
It's dead, Jim.
Totally. More slides to do. Some. I'm sorry. I don't know. We could probably restart and stop, but it's 8:20, so if you want to take a couple minutes to do that. I can't even.
It looks like we have some technical difficulties, right? Anyone have any questions up to this point?
Yes. So, no one take cases of what we call HLH or plus have to be treated for the what you call the low risk.
Yeah, not everyone needs to be treated, and I think Dr. Henry was going to go over some of those scenarios.
Some cases are limited, and other ones are generalized. So, some cases you don't have to treat it.
I think it depends on the clinical context. So if they're really sick, then yes, they need to be treated. But I was gonna point out that you have patients who have multiple organ failure and are really sick, end up in the ICU. Those are the ones that need to be treated. Okay, but there are a lot of patients who have it secondary to something else. Like for example, HSV. I have another case that in here that talks about a patient in the ICU who was intubated for influenza. Okay, and if you do a bone marrow on these kids, they will have hemophagocytosis in them. We've seen that. Okay, but what we say is, I don't want to commit this child to steroids and etoposide and stuff. So we would probably just treat the influenza, give supportive care, and it'll get better. There was a very challenging case, actually, most recently last month, in the ICU of a patient with Hodgkin's lymphoma who had hallmarks of HLH, but had polymicrobial sepsis and other viremias and stuff. And we did bone marrows on this child, and there's definitely something inflammatory going on, but we can never quite figure it out. We never really diagnosed the patient with HLH, and he ended up dying. We don't know why parents ended up electing not for an autopsy, but it's these unfortunate cases that really frustrate us as clinicians. So, do we ever get things working? I apologize. This was really exciting. All right. Well, in the few minutes we have left, actually, let me just. Yeah, I was going to talk about treatment real quick. And so the treatment that we have for HLH has really not changed since the first clinical trial was conceived in 1994, which is dexamethasone on an 8-week tapering schedule, and then biweekly, then weekly etoposide, and if they have CNS involvement, we use intrathecal methotrexate and hydrocortisone 4 times. And this really hasn't changed very much. And then what happens is that at the end of that 8 weeks, 3 things are going to happen. Okay, one of three things. Either you have the patient is going to completely recover and live happily ever after. Thank you for that, whoever. Nope, still no. And then the other thing that can happen is we have a patient who does not completely recover. Oh, there we go. Thank you. A patient does not completely recover, but there's no genetic mutation discovered, and they would go on to transplant, and they'd be on some kind of bridging therapy until then, which typically consists of dexamethasone, etoposide, alternating weeks, plus cyclosporin. And then there's a patient who, sometime in the first 8 weeks, has a genetic defect discovered. They go on to transplant immediately. And there are variations on this theme. So I actually prefer, instead of for continuation therapy, if a patient needs it, I actually prefer to use alemtuzumab, which is also called Campath, which is a monoclonal antibody to CD52. It is very well tolerated, doesn't have the toxic effects of cyclosporin, to your kidneys and everything. And you don't have to monitor levels, which is nice. And you give it like as an IV medicine every 4 to 6 weeks until they need transplantation. So we also use for Epstein-Barr virus-associated HLH, which is a very common trigger, probably one of the most common triggers. We use a medicine called rituximab, which is a monoclonal antibody to CD20. Why do we do this? Because EBV likes to hang out in the B cells, and so if you have a monoclonal antibody to CD20, which is a B cell marker, you trick the body into thinking that the B cell is bad. Right, so it gets opsonized in the spleen, it gets destroyed, and the EBV goes along with it. And a study at the Children's Hospital of Philadelphia actually uses to their advantage to demonstrate that we can really reduce the EBV load and all of the associated HLH features with as little as 1 dose of rituximab. So we actually have a patient in the hospital right now who was diagnosed with EBV-associated HLH who got the first dose of rituximab a few days ago. And we typically use rituximab until the EBV load is 0. It's very effective. So the other thing that we can do is I want to talk about transplant. And transplant is really only for those patients who do not make a full recovery after the first 8 weeks, okay? Or who have a genetic mutation. That's a given because it's going to come back if you don't. I had a patient actually who had HLH when he was like 10 years old, and then presented back 18 years of age with HLH again, but we didn't have the gene testing that back in when he was 10, back when he was younger, to identify the genetic cause of HLH that he had. We did have it when he was 18, and we were able to diagnose him, so he went through a transplant. We actually use what's called a reduced intensity transplant, which has a much lower dose and toxicity of what's called the conditioning regimen, which is the chemotherapy used to clear out the bone marrow to make way for the donor cells. Because most of the toxicities of bone marrow transplant are either end organ toxicity or infection-related stuff. And so using a reduced intensity regimen is much kinder on the patient. And then finally, and I apologize, I'm kind of skipping around in the slides here. One of the most exciting advances that are coming down the pike is a monoclonal antibody to gamma interferon. You'll remember that gamma interferon is one of the main cytokines that drives the disease, and we actually participated in a clinical trial a couple years ago that looked at the treatment of refractory HLH with this monoclonal antibody to gamma interferon. And unfortunately, it didn't work so well in our patient, but in most patients around the world, it actually works very well. And they're kind of gearing up for a phase 3 trial in the coming months. So let me finish up. So the take-home points is that HLH is actually a primary immune disorder. A lot of people lump it in with oncology. It really has nothing to do with oncology whatsoever. And the hematology side effects are kind of exactly a side effect, as a result of the hemophagocytosis in the bone marrow. So it's really a immune defect. So why, as hematologists, oncologists, do we treat it? Well, we're the ones who give out the chemo. There are established criteria, but you kind of have to take it with a grain of salt. You have to, use your clinical suspicion and clinical context to guide your therapy. And you also, I think it's really important to point out that HLH is a syndrome on a spectrum. Okay, it's not one size fits all. If you have HLH, it needs treatment. If you don't have HLH, it doesn't. So I think, again, you have to take into account the clinical context and and what's going on with the patient in order to guide decision making. So I think with that, I'm sorry about the technical difficulties. Are there any other questions? Yes. That's a very good question. So for those of you who haven't heard the question, he asked in the mouse model, did they use recombinant perforin? No, they didn't, because what we're talking about is now like a vector, gene therapy type thing. They did not do that. That would be an interesting study. And I don't know if that's in the works, but that would be very interesting. Any other questions?
Would you send somebody with a heterozygous defect to transplant?
With a what?
With a heterozygous genetic defect, instead of being two kids, if they have only one mutation,
Ooh,
would you send them to transplant after remission?
maybe. I think it all depends on. So I guess the first question is, how would I know that? So if they presented with an HLH-like syndrome and it turns out that they had a heterozygous defect, then that tells me that there's probably another heterozygous type defect in a gene that was possibly undiscovered. So in that case, I probably would. If I found it out by accident, and I don't know how that would happen, but then. And the patient has no history of anything going on, then I probably wouldn't. But that's a very good question.
Let me just add something onto that. So this gene panel that we're talking about, that's going to get about 70% of the genetic defects. It's not 100%. And if they got HLH and there's one thing, you can be compound heterozygote, and, so I think another question would be, what about the siblings of someone with familial HLH? Like, should they be transplanted too? But I don't know.
Well, I think they should be tested, and for the same genes. That's very easily done, and if they do, then they kind of become a ticking time bomb. And I think that they should be transplanted, which is a very hard sell, for parents.
One of the challenging situations that we sometimes face together is have a kid who presents with an infection, you treat the infection, but you're still seeing that the immune response is still out of proportion to where they are clinically, and it's always a question whether is it time to give them steroids, and it's not necessarily the full plan for HLH. Are there any specific studies that looked at an approach in a situation like that, where I guess then it's an HLH spectrum, but how long do you wait and give them time to recover on their own from the inflammatory response, or when do you intervene? I know it's kind of a blurry zone, but this is actually a more common situation than the straightforward HLH patients that we deal with. And we've seen it with Rocky Mountain spotted fever, with Streptococcus pneumoniae sepsis, and other bacterial or virus sepsis as well.
That's a very tough question, and these are the ones that keep me up at night. I think that if we have an explanation for the patient's symptoms, and like some kind of infection that we've identified. Like, for example, the patient with Hodgkin's lymphoma who had polymicrobial sepsis, et cetera. When do you pull the trigger and treat them with steroids and etoposide, or even just steroids? And I believe that patient was actually treated with steroids, probably not for HLH per se, but I guess it was kind of, you know, well, if the kid had HLH, then we'll be covering it, sort of. The best answer to your question is I don't know. You kind of have to take it on a case-by-case basis. And you kind of have to look at how sick the patient is, how much evidence you have for HLH. It's a very tricky question, and I don't have a good answer for you. You know, should that patient have been treated for HLH? Yeah, maybe.
I mean, he got steroids. There were some questions about whether he got better with the steroids, but you're right, he didn't get, HLH treatment. He got steroids.
So could the steroids have been treating the lymphoma too? Like, so if there's a malignancy-associated HLH, do you have to treat the malignancy for the HLH to respond?
If there's a malignancy-associated HLH, do you have to treat the malignancy? Well, if there's an anything-associated HLH, then your best shot of successful treatment is treating the anything. You know, whether it's treating the infection, like for example the EBV, or treating the malignancy, you know, and that does happen. You get coincident malignancy with HLH, and you know, and if you're lucky, etoposide will be part of the regimen to treat the malignancy. But if you're unlucky, you could at least start with steroids and try and knock things down. But those are very tough cases. I think we're out of time. So thank you for your attention. I appreciate it. And again, sorry for the IT difficulties.